Yeah, I
I want,
don't need you don't need to do anything. You can just head out, come back in, do what you want.
yeah, that's what I'll do.
Dr. Mensa just joined us. We'll give
Okay.
people a couple of minutes. And Jeffrey, can you send me this is Sharon
Hi.
Demenza. I don't know if you guys have met before.
Once I did because I subbed for doing this because usually one of the other girls do the lectures.
Right.
Sharon, what do you do with Gildas?
I run the virtual program from home.
What's you mean like the Zoom recordings?
Yeah, yeah.
Oh,
I
nice.
do all the workshops because I don't have a degree in social work, so I can't run a support group. But I
Uh,
can do lectures and the workshops. And then for our support groups at night or during the day or whenever, I go in, open it up, and then let the facilitator, if it's not an employee, in, and then just give the host to them and leave, and they let their people in.
that sounds awesome.
So
What's your
that
direct email through Gildas?
it's S H Transit, TRANSIT, at gildasclubdetroit.org.
And is this particularly geared towards the Detroit location?
I work out of Royal Oak.
I see.
We have the three. So don't send that to me. Send that to Megan, the
No,
program
I know.
director.
Yeah, I have Megan's email.
Yeah, send that to her
I just
because
wanted to
she'll
have
put it wherever they put
right,
them.
right. But just so I have it, SH Transit at gildasclubdetroit.org.
Yes,
Okay, and if something goes wrong for some strange reason, what's your cell phone?
it's 586
Mm-hmm.
899
Mm-hmm.
5564.
Okay, perfect. Um, Look at Dr. Lakshmi Salim has a
Oh, yeah, she's from the lake house. She does yoga for us.
oh nice. Okay, so yeah, go ahead and do what you need to do. Uh, Jeffrey, do you have any white slips or the link for the white slips? Yeah.
So, you know what? I'm gonna make you host and make Jeffrey co-host while I'm gone.
Okay. He doesn't
Oh,
have to be because he's not going to share a screen. I think you can only make me.
okay, I'll just make you host and then
Yeah.
I'll take it back when
Yeah.
I get back.
Yeah. Or just make me co-host. Either
Well,
way.
if I'm host though and leave, will I end the meeting?
Oh, I see what you're saying. Yeah, just make
Yeah.
host, Jan. Yeah, yeah,
So
yeah.
you're host right now.
Okay, perfect.
Hi, Dr. Lakshmi.
Hello.
Hello. So like quarter after, I'll leave and go let her in because she usually gets there at quarter after.
Okay. I'm just going to give it a couple more minutes before I get started. Now, Dr. Lakshmi, am I reading here correctly that you're a plastic surgeon or were trained as a plastic surgeon? Maybe she stepped off for a minute.
Yeah, she is.
Yes, I'm a plastic surgeon. I just muted myself. Yeah.
Oh, that's okay. I'm Sheba Roy. Nice to meet you. And
Nice to meet you. Yeah.
I'm assuming you were trained officially in India, is that right?
Yes, yes, yes. I'm the senior most, almost 75 years now.
Ah,
I I did the surgery for almost 40 years
oh,
practice.
Oh, wow.
and
Yeah.
you came to the States and continued, or you decided to move on to do something else here?
Actually, I moved because my daughter is a pediatric radiologist,
Uh-huh.
and we just wanted to spend time with the grandchildren and her. And so I took up yoga and meditation and got trained as a yoga teacher.
Oh, beautiful.
So I keep teaching yoga and meditation free for all the Gilda Club and also Neighborhood Club everywhere.
But no longer practicing in plastics.
No, but I do go to India to do some charity work for burnt victims.
Oh, beautiful. And you're in Hyderabad in India.
Yes, I was, and Vijayawada, my own
Mhm.
native place.
My father is from West Bengal.
West Bengal. Oh, that's great.
Mhm.
Was he a doctor?
He is a doctor, but he's retired now. He's an older man. He's older gentleman. He's 86 years old.
Okay. What specialty did he do?
Here in the States, you could start out in one thing and then re-specialize. So he
Yeah.
started out in gastroenterology,
Mm-hmm.
then re-boarded in geriatrics and then addiction medicine.
Oh, that's nice. Yeah.
And my mother was a pediatrician.
Oh, is she still working?
No, she's also retired.
Okay.
How about your daughter? Where does she practice?
She's a pediatric radiologist working in children's.
Oh, she's at Children's here in Michigan?
Yes, yes, yes.
Oh,
Yeah.
beautiful.
Yeah.
What,
And
what is her name?
Sheena Salim, she's heading the department.
Oh, beautiful. I don't know.
Yeah.
I don't see a lot of pediatrics though. Um,
Okay. Where do you work?
so I am going to introduce myself in just a minute, but I
Okay.
am a natural medicine doctor, but
Oh, I
I'm
see.
a special kind of natural medicine doctor because I'm trained in both conventional medicine and natural medicine, and I'm
Mhm.
board in something called integrative oncology, which
Oh, that's nice. Yeah. Maybe I can be of some help to you because I feel yoga and meditation um, do help a lot.
oh,
And
absolutely.
and
Absolutely.
also I have an organization started recently that is Cancer and Chronic Disease Survival Support Group.
Oh, beautiful. So we'll
So
exchange our
we
information.
can both help each other. Yeah.
Yeah, what is your email address?
Lakshmi, Lakshmi,
Mm-hmm.
dot
Mm-hmm.
Salim, Saleem,
Mm-hmm.
@gmail.com.
Mm-hmm.
You
I'll
can note my number 313
mm-hmm.
770
Mm-hmm.
6020.
So our clinic is supportive care oncology and it's multidisciplinary. We would love to have yoga meditation.
Yeah, where is your clinic?
We're in Troy right now, but we're affiliated with Beaumont, U of M, and Henry
Oh,
Ford.
that will be nice. I can be associated with you because I'm looking for something like that, like yoga therapy
Mm-hmm.
as an adjunct modality,
Mm-hmm.
not like treatment.
Mm-hmm.
And it can help them to ease the pain and go through the treatment.
Absolutely. We're
May I
boarded.
know your name, please?
Last name Roy, Roy.
Oh, yeah, Roy. I know. Bengali name.
Yes. First name Sheba, Sheb, like boy A.
Shiba. Yeah.
We'll go over though when we get started. We should probably get started now, Sharon. What do you think?
Yeah.
You're muted, my dear.
So I'm going to mute myself. Okay.
Yes, please.
Yeah.
Sharon, should we get started now? You're muted.
Hey, I'm so sorry. I'll be right with you. I've got somebody on the phone trying to get into their group.
Okay,
I've
let
got
me go. I'm
two
gonna.
other groups that need to be let in. Hang
That's
on.
okay. I'm gonna go ahead and get started then, just because we're running behind. Okay.
Hang on. I have the volume turned on so they couldn't hear.
Sorry, the clubhouse is packed right now.
I know.
too.
I'm sorry.
You go ahead
Something-
and take care of what you need to take care of, Sharon.
Okay, so I made you host and I'll be back.
Okay.
I'm going to leave.
9944.
Okay. Hey, Dr. Mensa, thank you for putting that up for me. Perfect. Wait, no, that's not the white slip, is it? No, I need the white slip. It's where you click to the link and it asks you for your email, etc. Can you ask Kasim for that? So in the interest of archiving this for Gilda's, today we're going to go over what to do when you're diagnosed with breast cancer. My name is Dr. Sheba, Sheb, like boy, A, Roy, Roy, and I am what's called a naturopathic or an integrative oncologist, which is kind of a fancy word for supportive care oncology. And what that means is I'm a natural medicine doctor. And in addition to having a doctoral degree in natural medicine, I have been trained in conventional medicine and have done a residency and fellowship in supportive care for oncology patients. There's 75 of us in the United States and 4 of us in Michigan. You're going to see on my top left screen there, Dr. Mensa, Jeffrey Mensa. And Dr. Mensa is completing his fellowship, 3-year fellowship in integrative or naturopathic oncology. So what that means for all of you, and I'm sorry, I'm getting over pneumonia, so I'm a little bit froggy today. But hopefully in this archive, you'll be able to excuse that. And by then I'll be very well when you watch this. What that means for you guys is our job is to manage the side effects of chemoradiation, surgery, prepare patients for going through treatment, make sure they go through treatment feeling well, and on the other side of treatment, work on lowering risk of recurrence in survivorship. If our patients come to us already having had a cancer that moved, we call that a stage 4 disease or a metastatic disease, then our job is to slow progression, support the patient in trying to move towards no evidence of disease or remission. And sometimes that means taking our patients all the way to last breath. We have a clinic in Troy. And at that clinic, we serve patients using lots of different means. So it's what's called a multidisciplinary clinic. And that means that we're using natural therapies, nutrition, somatic therapies. That means things like yoga, Reiki, massage, IV therapies. Sometimes we're working with your primary care doctor or your oncologist to use drug therapies or off-label drugs to help optimize your outcomes in survivorship, botanical therapies, Indian medicine, Chinese medicine. In other words, when you're faced with this diagnosis, there's so many ways to empower yourself to be well and to manage all of the things that come up, from fear of diagnosis itself to prevention of numbness and tingling in your fingers and toes, constipation, diarrhea, mouth sores, weight loss, pain, anxiety, sleep issues, hormonal changes, and cardiovascular risk of diabetes or metabolic disease, and heart and kidney disease long term. Those all fall under the umbrella of what we do at our clinic. And the name of our clinic is Associates of Integrative Medicine. And the website is aimnatural.com. So that's AIMnatural.com. Associates of Integrative Medicine.com. Now you can always call us if you don't have access to the web, and that's 248-798-2942. Or you can email us at dr.roy@aimnatural.com. Hopefully that's easy to see. Dr. Mensa, is that easy to see? Okay, perfect. He's saying yes. Good. So now that I've introduced myself a little bit, if you go to aimnatural.com, one of the things that I wanted to show you here is that you can access these videos. So we're going to pop this video up on our archives, and you can also access it through Gilda's archive. So you can go back and rewind and remember things that you might have forgotten. If you come down to the bottom of our website here, as you see on the top, aimnatural.com. If you come down to the bottom here and you click on this little video icon here, it'll connect you with all these talks that we do. And you can learn more about anything from food to genomic testing, to sex and intimacy, to nutrition. And it just helps you to stay current. Okay? Good. So let's talk breast cancer. So I'm going to start, and then I'll have Jeffrey Dr. Mensa jump in, and I'm going to start with what is breast cancer. And as I see people come into the room here, I'm going to ask them to stay muted if they aren't already. And again, I'll circle back at the end and I'll talk about how to watch this video. So, hi, Sarah. You can go ahead and turn off your video. Perfect. And mute yourself if you can. Let's talk about what is breast cancer. So, breast cancer is a disease that happens in the breasts, which are glandular tissue. Their job, as you may know, is to make milk, to feed babies. So that's really their only job. And as that gland ages, it can be subject to cancer because cancer essentially can be a disease of aging. So when we're talking about breast cancer, we're usually talking about a cancer of the ductal tissue. So as you can see here in this picture of a breast tissue here, these are the lobules where the milk is made, and these are the ducts where that milk is deposited in the nipple. And usually the places that we see cancer are in these ducts, and the reason is because those cells are often growing, and as they grow and change, which we'll learn about in just a minute, as cells grow and change, those cells are more subject to developing cancer. So there's multiple types of breast cancer. Besides invasive ductal cancer, we can see invasive lobular cancer, or we can see a precancerous lesion like DCIS or LCIS. I don't want to get into the nitty-gritty of all of that because I'm aware that the people who are watching right now and who may be watching later aren't really concerned about where the cancer is. As long as it's breast cancer, it's typically going to be treated the same way. You're going to see me jumping around a lot because I'm looking for pictures that I want to use to make it faster to teach you. You know, it's very expensive to see us, by the way, because consult with natural medicine in Michigan isn't covered by insurance. So one of the things that we've been working on is creating a video series on breast cancer for breast cancer patients, and hopefully we can expand it to all of our cancer patients, that helps them to understand how to manage this disease without necessarily having to see one of us. And so one of the things that you're going to see up here is some of the things that we've been working on with this video series. This is a table that goes over types of breast cancer. And I don't want to make this too word dense, but I'll basically say that as you go through your life cycle as a woman, you're exposed to estrogen, you're exposed to progesterone, because those hormones are what makes breast tissue grow and cycle through its development to create milk for a baby. So if you're diagnosed with breast cancer, it can be a hormone positive cancer. So if you've heard that you have a hormone positive cancer, it just means that the cancer cells grow because they're responding to estrogen or progesterone. If you have a HER2 positive cancer, you may have heard that term as well. It means the cancer cells grow because they're responding to a growth factor called HER2. So because of that, you can have a hormone positive, HER2 positive breast cancer, or you can have a hormone positive, HER2 negative breast cancer, or you can have a hormone positive or hormone negative, HER2 negative breast cancer, which would be triple negative. So all of that just tells you what things contribute to the growth of the cancer. Again, why do we care? We care because it tells us about treatment. Breast cancer is typically treated the same. You're going to see me open up a screen one more time here, and I promise I'm going to move on to the interesting parts in just a minute, but I want to give you a lay of the land. So when you are diagnosed with breast cancer, it's usually because you've found a lump, or you've seen something on a mammogram. And what happens first is they have to take a piece of that tissue, that's called a biopsy, look at it under a microscope, and generate what's called a pathology report. That pathology report will tell you what kind of cells were found in that tissue. Are they cancerous? Are they not? If they are cancer cells, it'll tell you whether they respond to estrogen, progesterone, or HER2/neu, that fancy word that we just mentioned. And in any case, whether it's estrogen, progesterone, or HER2/neu, these are just types of growth factors. Now we're going to come back to these in a minute. So you can have, after they generate a pathology report telling you what might have contributed to the growth of that cancer, they're also going to tell you what stage it is. Stage can be very scary for patients because you see things in the movies, you hear things on the radio or etc. that tell you what to be worried about, what not to be worried about. I'm going to ask people if they can mute themselves one more time. Thank you. But stage to us as doctors just tells us what we're going to do to treat. So what does that mean? So a stage 1 disease means that you have these are supposed to be breast tissues, by the way. These are supposed to be not the very best drawings of breasts, but let's just call these breasts. A stage 1 disease is a tumor that's fairly small, under 2 centimeters, and located in the breast itself. And that's going to get treated with surgery, then chemo, and usually radiation, depending on the aggressiveness of that little lump. A stage 2 disease can be a little bit larger of a tumor and still in the breast itself, so over 2 centimeters. And in this case, you're usually going to get surgery, chemo, or radiation. A stage 3 tumor, or somewhere between a stage 2 and a stage 3, is going to have moved out of the local breast and moved perhaps into a lymph node. A lymph node is a border control station in the armpit that is checking the breast tissue for disease. So this is a bad picture of an arm. This is supposed to be a lymph node here. And in this case, you're still going to get surgery, chemo, and radiation. You may also, though, get chemo prior to surgery to make this tumor smaller so that when they do the surgery, they get all of the disease. If you're diagnosed with that tumor somewhere else in your body, so breast cancer can move, and it can move to usually the bone, the liver, or the brain. Now, I don't want you to be scared of that. We'll talk about that in just a minute. If it has moved, then the treatment is usually chemo. So the reason why you're staged and the reason why they look at what growth factors are contributing to the disease is only to determine treatment. It doesn't mean that this is a stage of death and dying. I have breast cancer patients who've been with me for 17 years with stage 4 disease who are still in treatment and doing well. Half of our patients come to us stage 4. I've had patients come to us with brain, bone, and liver disease who are still doing well 9 years out. Breast cancer is one of the most heavily researched and best funded diseases. So there's new treatments all the time. And in some ways, we're treating it now like a chronic illness. In the sense that as treatment changes, you may need to change what you're doing to approach it, but it doesn't mean that it's a death sentence. I'm going to pause here and have Dr. Mensah jump in and save my voice a little bit. And he's going to talk about what drugs are used for treatment. So we're going to go over adriamycin, Cytoxan, Taxotere, and we're also going to talk about a drug called Herceptin. There are other drugs that are used for chemotherapy in breast cancer, but this is for a patient who's newly diagnosed. So those are kind of the main ones that we're going to see up front. And Dr. Mensah is going to go over the names of those drugs, the common names of those drugs, how they work, and what the typical side effects are. And then he'll bring it back to me. You have to unmute yourself.
Oh, can you hear me now?
I can hear you now, and I'm gonna pin you instead of me. Perfect.
Let me
Are
see.
you a co-host?
I don't think I'm the co-host yet.
Okay. Let me see if I can make you the co-host. Shoot, without Sharon on. I don't know if she's on.
I can do it. Let me see. I can take myself
Perfect. And just put
um,
Sharon's as a
well,
co-host.
hang on 1 minute. I gotta reclaim host to make him co-host. Hang on.
Perfect.
Okay. And then
Perfect.
I'll make you host again.
Perfect.
Okay.
So Dr. Mensah, if you could just review those 4 drugs,
hmm
common names,
hmm
and the most common side effects, how they work and the most common side effects.
Yeah, let me share my screen. Documents, whiteboard, view whiteboard. Perfect. I'm just kind of trying to move my text box so my name doesn't cover up what I'm typing here.
Your name isn't covering it up. It's just they've updated Zoom, so it's annoying. You can just type as you go.
Oh, I can just type as I go. I see. Okay. So, with standard treatments with chemotherapy for breast disease, drugs that we see, as Dr. Roy was mentioning, are adriamycin, Cytoxan, and Taxotere. Okay, so these are a part of the oldest, I call them families of drugs. There's about 6 of them that we originally started to treat people with cancer. Okay, so these are well studied and we do understand their side effects quite well. So I like to start talking with Taxotere because a part of our job, that's my job and Dr. Roy's job, is to be a bridge between conventional therapies and natural therapies. Taxotere comes from a family of drugs called taxanes. I bring this up with patients because taxanes classically don't like to play nicely with natural therapies. So, what does that mean if you see a doctor like myself or Dr. Roy? When your oncologist puts you on this ACT or AC then T regimen for breast disease, we talk about what natural therapies would play nicely, meaning will not have interactions or contraindications with taking this Taxotere. Okay, so when we think about Taxotere, what types of things can happen? One side effect is what we call peripheral neuropathy. That I'm putting PNP for short. What that means is it's a pins and needles in the fingertips and toes. Okay. Sometimes it can be more than annoying, it can be painful and debilitating to the point where it gets difficult to tie your shoes, zip up a zipper, button your shirt or blouse. Okay. Secondly, another thing that our taxanes and specifically Taxotere can cause is constipation. Okay. And we do a number of things to prevent these side effects. And Dr. Roy will talk about these things in a moment. Okay. What about Cytoxan? Sometimes, if you're looking at your chemotherapy bags that are hung next to you during your infusions, it's going to be called a name called cyclophosphamide. It comes from a mustard seed gas. Okay. Oftentimes, what we see with this Cytoxan is fatigue. While difficult, there are several strategies we can use for fatigue. For example, you may want to think about how you're exercising and how you are nourishing yourself with foods. Okay. And then we have adriamycin. Adriamycin, it's also called doxorubicin. Sometimes people do call it the red devil in support groups. Sometimes you may hear it be called that in your hospital systems. I really don't like when patients use that word because it makes it scary and it kind of puts a stigma behind getting chemotherapy. These are all drugs that are well studied and are effective for your type of disease. Okay. One thing that I do want to bring up about adriamycin, the most that I get worried about with this drug, also called doxorubicin, is the cardiovascular risk. Okay, that just means this drug can take a toll on your heart. I usually explain to patients that chemotherapy, it's very, very expensive to the body. You want to think about them as independent contractors. So these chemotherapies, they're coming in and you hire them to do a specific job. Each one of them is going to use up a resource, a nutrient in the body to do that job as a payment. Okay. Now, when you see doctors like myself or Dr. Roy, what we like to do is prevent these pieces from happening before they start. That's a foolproof way to make sure you sail through treatment very, very well. Okay. Dr. Roy also mentioned a drug called Herceptin. When do we get that drug? So you may remember just a moment ago, if this is a breast tissue, there are different growth factors that make this breast cancer tissue grow. So if in here is the lesion that we're looking at, there'll be different doorways that make this cancer grow. One that Dr. Roy talked about was an E for estrogen. Another one that Dr. Roy talked about was a P for progesterone. And another doorway that Dr. Ray mentioned is an H for her to new. When we have a doorway that opens up to feed a cancer cell through this her to new hallway, that's when we are called her to positive, which means our oncologist will give us a drug called Herceptin. Now, why is Herceptin a little bit different? So, Herceptin is a new generation of chemotherapies, meaning it's not a part of our original classes. So, when we're talking about Herceptin, it's a monoclonal antibody. Trastuzumab is its common name. Okay. When we're thinking about these monoclonal antibodies, they work a little bit differently. So, for example, this Herceptin, what it's doing, it's a worker that comes in and it wants to shut down this HER2 hallway or highway, meaning that there's no way that resources can get through that highway to that breast cancer cell. When we think about our side effects, they work a little bit differently. So instead of causing things like specific side effects, if it's like peripheral neuropathy or diarrhea, you want to think about these monoclonal antibodies causing more organ or system-based type of issues. For example, with people taking Herceptin, things that I also think about are cardiovascular issues. I also may want to protect their gut health. Oops, and I think there's someone in the waiting room. I'm not sure if I can let them in or not, if our host is still
No,
here.
we're all set. No
Or-
worries.
Okay, perfect. And sometimes when we're thinking about these things for Herceptin, where's my cursor? We have these heart issues, gut issues. We may also want to be thinking about things if they would harm our skin, if these monoclonal antibodies, for example, would be harmful to other hormone organs like our thyroid. But usually for Herceptin, I think about your heart, I think about lungs, I think about the gut. Okay. Now, when Dr. Roy is going to talk about, she's going to talk about how we prevent these issues.
Okay, awesome. Thanks, Jeffrey. So Sharon, if you could just give me my hosting back so that I can uh undo this if you haven't already. Um,
Yep, your host again.
okay, perfect. So Dr. Mensah used some scary words, and I just want to emphasize that chemotherapies, to a large extent, are a part of the natural world, meaning most of them have been sourced by plants and flowers. In the 60s, the US government sent all these researchers all over the world to harvest plants and flowers and trees and soil and see if we could find some cures for cancer. And there's really only 6 or so classes of cancer drugs that are called chemotherapy. And those drugs mostly are from things like the bark of the Pacific yew tree. The whole class of taxanes, including taxotere, are from that source. Or the Madagascar periwinkle gave us a group of drugs called the vincristines and the vinblastines, or the Chinese happy tree or Acuminata. Happy Tree gave us the topotekans and the irinotekans, which are drugs that are used mostly for colorectal, but you might sometimes see them with other cancers. So it's all part of God's green earth, and it's not about being afraid of drug treatment. It's about uh, learning how to embrace treatment. In fact, studies show us that our approach, our mental and emotional approach to treatment, is sometimes more important than the drug itself. For example, we run what's called an evidence-informed or evidence-based clinic, meaning we don't just offer natural therapies willy-nilly. Almost every natural therapy has evidence, but the question is what kind of evidence? But if we look at mindfulness, if we look at how we use the power of our minds, and we look at cancer treatment. This is pubmed.gov. This is where the government publishes all data done anywhere in the world at any time about cancer and any other disease. If I put in mindfulness in cancer, you'll see there's 2,400 studies that are done looking at even the risk of recurrence and our outlook towards cancer. And if I filter for clinical trial here on the left, which you can also do yourself, you can go to pubmed.gov, G-O-V, put in anything you want. Let's say somebody told you about blueberries and cancer, you can put that in. Let's say you were on Instagram and somebody told you about cranberries and cancer, or I don't know, cayenne pepper and cancer. You can put that in and you'll see if there's any data. And you can filter on the left here for clinical trial. When you filter on the left, it gives us the human data and hospital-based studies. And as you can see, there's still a lot of data for mindfulness and cancer. And we see a beautiful study here with breast cancer that looks at mindfulness, which is a way of staying in the present moment, and how it impacts distress, fear of recurrence, fatigue, spiritual well-being and quality of life. This is a randomized control trial. And we see that there was a significant difference in outcomes for patients even after just a month of doing mindfulness-based cognitive therapy. I don't want to get into the nitty-gritty of all different kinds of mindfulness right now, because that's not what this talk is about. But what I do want to say is how we think about treatment is one of the most powerful pieces of how we're empowered in being diagnosed with breast cancer. So when we think about chemotherapy, it's really important to not be afraid, or any part of our treatment, radiation, surgery, prophylactic drugs, survivorship, any part of our treatment, it's really important to approach it from a perspective of empowerment. I love this guided visualization that's narrated by a woman named Bella Ruth Naparstek, and I'm going to share my screen and put it up here from you. You can get it off of Amazon or Audible, and that guided visualization is called Fight Cancer. It's a beautiful imagery that helps to recruit the immune system to fighting cancer, whether you're in survivorship, whether you were just diagnosed, or whether you have a stage 4 disease. This is one of the most powerful tools we have. And again, if I went back to pubmed.gov and I put it in guided visualization or meditation in cancer, you'll see a ton of clinical data looking at yoga meditation, looking at mindfulness meditation, looking at guided visualization and cancer. And it's particularly effective for young cancer survivors, but really everybody can benefit. I want to go back to drug treatment. So we were talking about, or Dr. Mensah was talking about a couple drugs, and he was mentioning some side effects. So I want to just pop these side effects up here and talk about actually, no, I don't want to pop the side effects up yet. Before I do that, I want to do this. Okay. Before I do that, I want to talk about how we approach a breast cancer patient, or any cancer patient, but particularly breast cancer. When a patient comes into our clinic and they're diagnosed with breast cancer, the first thing we do is go over the pathology report, because the pathology report gives us that information that tells us what are the drivers for this disease. After going over that pathology report, we go over the imaging with the patient. And the imaging is like a CT scan or an MRI or a PET CT. And usually in this case, it's going to be a CT scan. That CT scan is going to tell us where disease is in the body, if there is disease in the body, but it'll also give us a lot of incidental information, meaning are you at risk for heart disease? Dr. Mensah mentioned that some of these drugs can create a cardiovascular risk. That doesn't mean just now, it means 15 years from now. So looking at the imaging can tell us, do we have a problem with clogging of the pipes that lead from the heart? Do we have other risks that will tell us maybe this person struggles with constipation? That would show up on a CT scan. Maybe this person struggles with gallbladder issues. That's going to show up on a CT scan. And that gives us a better picture of what we're facing going into diagnosis. Because one of the problems with cancer treatment is your cancer doctor has a very narrow view of how to treat this disease. And it's usually just about focusing on the lesion itself and using targeted therapies to fight that cancer. And that's great. We want a general in a war, but we also want to look at the environment in which that war is happening, right? What's going to happen to the civilians? What's going to happen to the infrastructure? What are we going to be able to run our schools during this war? What's going on with the community center? You are a whole ecosystem. You're a whole person, and all of those pieces matter and need to stay well and functioning while we're going through treatment. So After looking at imaging, we look at blood work. And the blood work that we do is far more comprehensive than what your cancer doctor does because we're looking at a bigger picture here. And so I'm going to pop up here and I'm going to preserve a patient's anonymity here by taking out their identifying information. But I'm going to pop up here, a breast cancer patient's blood work, so you can get a sense of the kind of blood work we do and how comprehensive it may be. And I'll use, let's see, we'll use someone that we saw fairly recently for breast. And I'm going to share my screen with you, and I'm going to show you the kind of blood work that we are doing. Now, your insurance will cover all of these pieces. They don't cover the cost of consult, but they do cover the cost of medical care, including your blood work, procedures, referrals, all of which we write for you. So this is a patient who is getting blood work done for establishing a plan for fighting breast cancer. So your cancer doctor is going to look at your liver, lungs, and kidneys, which are here. They're also going to look at your bone marrow. But what they're not going to look at is maybe some other pieces. So we would go through this blood work step by step and explain it to you. And it doesn't look like I have the time to do that today, but I'm going to show you the level of depth to which we go through it so you understand a little better of how we're treating you. For example, in this person's blood work here, we're looking at how their body manages fat and sugar. Why is that important? Because how your body uses fat and sugar is not going to just help you fight disease, but it's also going to help you once you're done with treatment with lowering your risk of recurrence. So, for example, we'll be looking at this patient's cholesterol. In this case, her total cholesterol is excellent at a 149. Her HDL, that's her good cholesterol, the kind of cholesterol that'll protect her from heart disease and from cancer. This is a measurement of the amount of plant sterols or good cholesterol in her bloodstream. I want to see this at a 60. So these normal ranges aren't what I want to see. I want to see this at a 60 for her. These are her dietary cholesterols. I'm talking about what she's eating. Her triglycerides are a measurement of the amount of animal fat or saturated fat in her bloodstream. This value will lend itself to heart disease and cancer as well as diabetes. And she's not eating any. I want to see this under 100, and she's doing beautifully. She's under a 50. Her LDL is her family history cholesterol. This is an inherited type of bad cholesterol. It usually doesn't respond as well to what we're eating. It responds better to supplement and drugs. And I want to see this cholesterol under 100. As you can see, the normal ranges are not where I want her to be. And that's because I'm individualizing this plan to this patient's risk. Now, if this patient was also getting adriamycin, which Dr. Mensah mentioned, the other word for that is doxorubicin. Dr. Mensah mentioned that this drug can cause myosin, can also cause heart disease. If she's getting adriamycin and she's a person who doesn't exercise, and she's a person whose mother had heart issues, and maybe she's a Black girl, then I'm going to work to bring this LDL under a 70. So the value for her is going to change because of her compound risk. Now, let's say she's also getting radiation, and let's say she had an estrogen positive disease, which means she's going to get a drug to block estrogen after treatment. Now I'm adding more and more risk to her heart, and I may want to bring that LDL down to a 50. So it really depends on this particular individual and what her particular risk factors are. And every patient, of course, has a different risk. So when we talk about individualizing care, it's very important to look at imaging, blood work, and pathology report in a very specific way, not as in, I just need drug treatment. So I'm going to have Dr. Mensah step in again now and talk a little bit about these particular side effects. So we mentioned some side effects here, and I'm just going to pop them up on the screen so he remembers what exactly those side effects are. We don't need the white slips as much, Jeffrey, because there's no one really on, and this is going to be archived, except for Dr. Lakshmi, and we already have her information. But the side effects from drug treatment can be things like fatigue, as Dr. Mensah mentioned, numbness and tingling in the fingers and toes, cardiovascular risk, kidney risk. And let's just talk about these big ones, constipation. And anxiety. Why don't we both unmute ourselves here and let's both kind of discuss this risk.
Mhm.
So, Dr. Mensah, what do you typically see works well for fatigue that that doesn't conflict with adriamycin, Cytoxan, Taxotere, or Herceptin? So I mentioned that to say, because we are specialists in integrative oncology, we are board certified on the interactions between drugs, natural therapies, nutrition in a cancer population. So we're educated in the pharmacokinetics and the pharmacometabolism of how all of that interacts, which is why we can both individualize the treatment and make sure you stay safe and are able to take these things without interacting with your primary treatment. You can go ahead and head out, Sharon. Thank you so much. Dr. Mensah.
Yeah, so for fatigue, things that I see that are useful for fatigue is one, on a base level and found for the foundational pieces, increasing the protein and nutrient status. So when I'm looking at a patient's blood work and I look through their kidney function and I see that their kidney function is excellent, okay, what I like to do is I like to take their weight that they currently have, I convert that weight from pounds to kilograms. Okay. When I have that kilogram in their weight, okay, per their weight in kilograms, I give them anywhere from a 20% increase to a 50% increase of their weight in kilograms for their protein. Okay. I also
Can you make that simple for me? So if someone weighs 150 pounds, or I'm saying, let's say 150 kilograms, excuse me.
Yeah, that's a good question. So if someone was, let's say 100 to even keep the number,
Okay.
even cleaner, if someone was like 100 kilograms, then I would say you need to be getting anywhere from 120 to 150 grams of protein per day.
And what is is 1 gram like a deck of cards? Or is
Oh,
it?
yeah, that's a good question. So, depending on the type of food you're eating, that may change. So, if you're talking about, let's say, if it is 100 grams or 150 grams of, let's say, chicken, that would probably be the amount of chicken that fits on the palm of your hand. Versus if you're getting about 100 grams of protein from, let's say, only vegetables, that might be a full cup or 2 cups of vegetables, actually.
Okay, that makes sense. Thank you.
Mm-hmm.
So the goal is to increase the protein and also to eat that protein in a more timed manner. So one of the problems with people during treatment is they don't feel like eating. They don't feel like eating for a lot of reasons, and that's okay. You don't need to necessarily eat around the time of treatment, but you do need to eat outside of that. And one of the biggest misconceptions that patients have is that you need to eat healthy once you're diagnosed with cancer. That's not necessarily true. It's fine if you do, but the horse has already left the barn, so to speak, and this isn't the time to be dieting. It's really a time to maintain your weight, because weight maintenance is what allows you to tolerate drug treatment and radiation and get through it optimally well. And because you're not as motivated to eat, it's really about what you have a taste for. So if you have a taste for a McDonald's chocolate milkshake, that's what you should be eating when you go through treatment. It doesn't mean that food is not, it doesn't mean that nutrition is not medicine. It means that this isn't the time to take that kind of medicine in that way. But one of the things that we do to make sure that you can eat is work on your taste issues. So we like to see patients use a baking soda mouthwash, so baking soda, water, and sometimes we can add to that folic acid, liquid folic acid, as a swish and spit. You may not swallow this, swish and spit. I want to emphasize spit again. You do not want to be swallowing folic acid when you have a cancer diagnosis, because it will potentiate cancer growth. That will help to preserve taste, and also zinc cold and flu lozenges after meals will help to preserve taste. And motivate you to eat. But going back to the protein, making sure that you're eating something with protein fairly regularly every 3 to 4 hours on the days that you are eating. So good. Any other strategies that we use for fatigue that don't conflict with adriamycin, Cytoxan, Taxotere?
Yeah, that's a good question. So another foundational piece, like a foundational of health, if you will, that I would use for fatigue is a low intensity physical activity. Okay, emphasis on the low intensity. This is things like walking. You can even do walking in water. This can be yoga. Yin yoga is especially effective. And what that's doing is point of the physical activity is to improve your circulation to give you that boost of energy. It's not to get a workout in, it's not to burn calories.
Right, so I think that's a really good point. And if we go back to that pubmed.gov that we were talking about before, and we look at the data around exercise, 15 minutes a day of physical exercise is all you need when you're going through treatment. And as Dr. Mensah said, it should be low intensity. Another thing that we use for fatigue that isn't contraindicated with treatment and is in fact synergistic with adriamycin and Herceptin is CoQ10. It cannot be taken with radiation. Now, there's a problem with giving patients supplements, and Dr. Mensah is going to talk a little bit about that issue while I blow my nose.
Yeah, so with our supplements, it's kind of what I call open season right now. So in the last 10 years, we can appreciate how the supplement industry has grown to a multi-billion-dollar space. That's good for the people making these supplements, of course. Why it might be an issue is because our drugs that we get for chemotherapy and treatment are regulated far differently than the supplements that we get at the store. Okay. So with our drugs that we get in treatment, they're regulated by the FDA, and they are very, very strict about what drugs are approved and what drugs are not approved for someone getting treatment. Okay. They actually go through like a three-step process for each drug before they even allow it to be sold to you on the market from a doctor. However, your supplements work a little bit differently. They're more regulated by the USDA. That's the US Department of Agriculture. What they are really overseeing, it's kind of looking at your supplements as a food product. Okay. So if I was a supplement company, right, and Dr. Roy was the USDA, and I said, I want to sell bananas, and my bananas are going to cure cancer. As an aside, bananas will not cure cancer, so do not have that as a takeaway from today. All that Dr. Roy from the USDA is going to say to me, she's going to ask, are bananas somewhere in that bottle of supplements? I'm going to say yes. And then Dr. Roy is going to say, okay, you are cleared to sell your banana supplement. Okay.
That means that what it says on the bottle may not be what's in the bottle. It means it may not be effective for what they're saying that it's effective for. It may be mislabeled. It may have contamination issues. And as long as it doesn't kill you, it can be sold as a supplement, or as long as it doesn't harm you. The problem with that is that when you're taking supplements with cancer diagnosis in particular, is they need to be pharmaceutical grade. They need to have gone through voluntarily an FDA-like process. And the only way to access those kinds of supplements is typically through a doctor. But your cancer doctor is not going to avail you of those because they aren't really aware. And their biggest concern is contraindication, meaning, are you going to take something that's going to compete with your chemotherapy? So coming back to the side effects that we were talking about there, the CoQ10 is also effective for lowering the risk of cardiovascular disease and also helping with fatigue. But it does need to be a high quality brand that's pharmaceutical grade. Now, our patients access their supplements through a pharmaceutical distributor, and we have them use Be Well with AIM. The password for that is AIM. That's for our patients. So you really do need to contact us first, and talk to us about what is safe for you. So I don't want to talk. I shouldn't have gotten off the rails here a little bit and talked about supplements too much. But let's talk now about botanical teas and kidney or nephrotoxicity. Nephrotoxicity means damage to the kidneys. What about botanicals and nephrotoxicity, Dr. Mensa?
Yeah, so with the kidneys, they're very, very important because they're filtering the bloodstream of waste, debris, trash, and they dump all that trash into the urine that you pee into the toilet. The factory workers that are in your kidneys are very, very sensitive. So whenever we get nephrotoxicity, that's toxicity damage, as Dr. Roy said, nephro being to the kidneys. Herbs that I think about are botanicals will be things like slippery elm. I think about marshmallow. I also think about corn silk. I also think about horsetail. I also think about a bright yellow daisy called marigold.
So marigold or calendula is particularly important because it's a wound healer. Now, these herbs can be heavily contaminated with herbicides and pesticides. So when we're making these teas, we're using sustainable organic herbs that we know are sourced from high quality farmers. These teas can be super effective in preventing radiation-induced cystitis or nephrotoxicity associated with chemotherapy. We're really talking about kind of gentle general therapies here. We're not talking too much about supplements, but again, going back to that CoQ10, it is also protective for the kidneys. And moving on to constipation, that slippery elm and that marshmallow can be helpful for constipation. But one of the most important therapies that we use is something called magnesium citrate, which Dr. Mintz is going to talk about.
So magnesium citrate is one of several different types of magnesium. Now, the reason why Dr. Roy wrote out citrate for us is because it's very, very specific on which type of magnesium you're using for a specific goal, okay? So the magnesium that I'd want to give you, for example, for your constipation may be different than a magnesium that I want to give you to protect your nerves, or different from a magnesium that I would use to protect your heart. Okay, this magnesium citrate, it's good because it gently moves the bowels, so it helps prevent and treat that constipation that we see from that taxane exposure. Okay, there's a different type of magnesium called magnesium glycinate. I love this type of magnesium because, one, I think of it as an overall body nutrient that we use, and it's well absorbed, meaning your body's not just going to dump this into the gut, not being able to absorb it. That magnesium glycinate that Dr. Roy so kindly wrote out for us, it's going to help protect our bones. It's also going to help protect our blood vessels from that adriamycin exposure. It also helps as a pain adjunct when we're having any pain from chemotherapy, pain from treatment, pain from radiation as well.
Now, the last thing that we're talking about here is nerve toxicity. So, another way of calling that is neurotoxicity or peripheral neuropathy. Magnesium is a mainstay here, and there is no tolerable upper limit for magnesium, meaning you can dose as high as you want as long as it's in a glycinate form, which, as Dr. Mensah mentioned, is bowel neutral, so it won't cause constipation. It doesn't have, unless you have, there really isn't any contraindication with using a high dose of magnesium, but we also use vitamins B6 and B12 here. Now, these can be taken over the counter. There's no problems with taking any of these three over the counter. There's no problems with contamination or source issues or brand issues. B6 is a very specific dose. It has to be between 150 and 200 milligrams, and it has to be really tightly titrated there. B12 can be anywhere from 1 milligram to 2 milligrams daily. These are extremely helpful for that nerve pain. However, sometimes people will buy a B complex plus B12 over the counter and think that that's helpful for them, and it's not, because it contains folic acid and iron. Why are those a problem, Dr. Mensah?
That's a good question. So, with folic acid is a fancy word for your B9 vitamin. Both your B9 vitamin or folic acid and iron are contributing growth factors to cancer cells. What that means is whenever a cancer cell is roaming the body, they like to use these two nutrients to help protect, repair, and grow themselves in the body.
So we're just going to talk about one more nutrient, and that's fish oil. Fish oil is also helpful for prevention of neurotoxicity. It's also a nice cancer fighter. If we go back to to PubMed.gov and we look at the data here around fish oil, we'll see that there's a ton of data on fish oil and cancer. Now, fish oil is problematic. There's a lot of problems with it, and one of the problems is source and contamination issues. So fish oil, if it's not from a pharmaceutical grade source, and the only sources that we trust are Nordic Naturals, and over the counter, I'm saying, are Nordic Naturals over the counter. In terms of pharmaceutical grade, there's Pure NCAPS, Thorne, Vital Nutrients, which you usually can't source over the counter. But fish oil is a problem because fish are a large fatty animal, and they're absorbing a lot of the pollution that we throw into the water. So when we source the oil, we also source that pollution. So it needs to be from wild-caught cold water fish from healthy waters, which is hard to find. The other problem with fish oil is if you have a history of smoking, then it can also increase your risk of things like lung cancer, or if you have prostate, it can increase the risk of aggressive outcomes with prostate disease, or if you get prostate disease, it can be more aggressive if you've been taking high doses of fish oil. Fish oil is can also cause reflux if it's not high quality. It sometimes needs to be kept in the refrigerator. So we're saying all these things just to talk about how even though all of these things can be useful, there's always issues with interaction, with history, with source, with brand. And it's very important to make sure you're seeing someone like us who has the letters NDFABNO after their name so that we can help you with really truly having the best outcomes possible. Now we've talked for about an hour and we only have 2 people here in person to ask us questions, but I want to open it up for a couple of questions if people have them. And I just wanted to also write out those letters because I said them super fast. If you're looking for an integrative oncologist, you can go to the oncanp.org. And you're looking for someone with the letters FABNO after their name. That means they're board certified in the pharmacokinetics and the pharmacometabolism of how all of these things interact with drug treatment, surgery, and radiation for cancer patients. Okay, Maddie and Dr. Salim, questions? And if you don't have any, that's just fine. We're 11 minutes over, so we're over talking here. And it doesn't have,
It has been a very nice lecture, and it's very useful for the patient as well as for me.
good.
Congratulations. Yeah, it's
Good.
very nicely presented.
Thank you. Maddie, any questions for us?
Not that I can think of. Maybe as a yoga teacher and meditation teaching, I feel that will help as an adjunct treatment for the patients who are going through the treatment of chemo, radiation, or surgery. That can be considered as a possibility of easing the pain and also tolerating the treatments. That's all I can say. This is a contribution.
And I hope that's something that we touched on, but we'll bring it up again. So Dr. Salim is mentioning yoga and cancer. And again, if we put that into PubMed here and we click on clinical trial on the left, you'll see there's a ton of data,
Yeah,
particularly
that's true.
looking at anxiety and depression with cancer, but also pain. And in fact, outcomes. The most effective use of yoga is yoga and meditation over a 6-week period. And there's very strong data in breast cancer survivors looking at outcomes. One of the biggest things that people struggle with when they're diagnosed with cancer is fear. And so feeling like there's always another shoe that's going to drop. There's this monster in the closet, facing this idea that our lives are limited or there's an end to our lives. And one of the things that's most important as we go through this journey is to perhaps broaden our mind to think about it as an invitation in our life from our Creator or from the universe to consider, what is the meaning of my life? What am I here for? Who loves me? Who do I love in return? What is the value or the purpose of my existence? And perhaps sometimes it takes bringing us to our knees to have these conversations. But one of the reasons why yoga, meditation, Reiki, guided visualization, mindfulness is so effective in helping us to manage this journey is because it takes us out of that place of fear and moves us into a place of being more open to those conversations and thinking about, what is the purpose of my life? Identifying that purpose and identifying your joy is one of the most profound things you can do to fight this disease. And I will also say that skin to skin contact and in terms of massage and yoga, I've seen excellent data looking at massage and yoga over an 8-week period, showing significant reduction in anxiety, depression, and pain. Skin to skin contact, being centered, being connected to your body, helps you to get to this place where you can relinquish fear and move towards a place of love, because your life matters. You're here for a reason. You're not here for to fight to survive. In fact, I hate the word survivorship because it doesn't really tell us or indicate what we're really here for. I like the word thrivership because it's asking us to consider what the value of our life is. In fact, we're all connected in this one cosmos, this one being. The word yoga comes from the word yuj, to unite, to connect. And I think it's a wonderful way to close, to think of how we're all connected in this one consciousness, this one life. And there's a purpose for each one of us as cells in one being to move forward. This disease is not your identity. It is not a prescription or a prognosis. It is not a determination. It's simply a suggestion to open your mind and think differently about how you've shown up in this world. And with that, we'll close. Again, my name is Dr. Roy, R-O-Y, and this is Dr. Mensah, Jeffrey Mensah, who's been with us today. And you can reach us or find us at aimnatural.com, or you can call us at 248-798-2942. And hopefully, we hope to see all of you and to be useful to you in living your best lives. Thank you for your attention today. If you want to log on to a website and look at other talks, you can do that. And until then, be well.